Welcome to the World Institute of Critical Care and Emergency Medicine, a non-profit educational organization built by physicians for physicians with a mission to improve global healthcare. Our goal is simple: to help healthcare professionals around the world make informed decisions, enhance critical thinking, and excel under pressure, especially in high-stakes, critical, and emergency situations. WICCEM offers comprehensive training and resources in critical care and emergency medicine, featuring a core curriculum that covers adult and pediatric care, with courses in pulmonary, cardiovascular, and neurology specialties. From advanced training in emerging techniques to hands-on experiences in critical care, life support, and emergency medicine, our programs are designed to equip you with the skills needed to thrive in demanding environments. Our expert faculty, who offer lectures, mentorship, and innovative insights through annual conferences and webinars. With our online learning platform, you can access courses, workshops, and a rich library of resources from anywhere in the world, making education accessible no matter your location. WICCEM also provides certifications and CME credits to support your professional growth and ensure you stay at the forefront of the field. We also foster a global community of healthcare professionals dedicated to advancing the field and improving patient care worldwide, especially in resource-limited settings. Join us at World Institute of Critical Care and Emergency Medicine, where we empower you to make a lasting impact in healthcare. Welcome.
Thank you, everybody. Hi, my name is Wafa Aish. I'm a consultant clinical dietitian, president of MAYAPEN, and the president of Emirates Pen Society. First, allow me to thank the World Institute of Critical Care Emergency Medicine for these fellowships that we are having. First was the critical care, then the obesity. And that was a question from Dr. Ramadan, my other moderator for today's webinar. And I hope I answered, so Khalid is there with us to answer the questions, because so many people said why the Institute is giving an obesity fellowship. Well, if you see the last slide, they said that they are giving a lot of CMEs, a lot of fellowships to enhance your, let's say, education. Now, we're talking about the modules. The modules, Maysoon, can we have it from the beginning, please, my dear friend? This is now we're going to talk about the fellowship, which is a new fellowship in the weight management and obesity medicine. I'm going to take you in a quick tour before introducing our guest speaker for the first and the moderator. Second, can I have next, please? Okay, the detailed program. We are having 2 modules. It's going to be like 17 weeks, 3 chapters, each chapter made from 4 topics. Each topic runs in 1 week. And we have a case presentation with a discussion. Webinars like today's webinar, last month webinar for 4 weeks. And then we have in the first module, which we go for the basics, the fundamental, 4 lecture, Introduction to Obesity, Body Composition Assessment, Genetics and Obesity, Metabolic Syndrome and Insulin Resistance. Then from the fundamental to the science, what it says, nutrition management, EV dietary approaches, the role of complementary medicine, and definitely psychology, which plays an important role in eating disorders. From that, we go for the life modification, which is an important pillar in obesity control, talking about exercise and novel therapeutic targeted. Next. We have, of course, In the second module, we go from that to the pharmacology, the GLP-1s and others. We go for bariatric surgery, but bariatric nutrition from childhood to geriatric and women health. Again, 4 lectures, special population with advanced 3 lectures. Targeted minds, weight management, complication. This is a sample of what we're gonna have with an amazing speakers in the first date, which started 24th of March, 2026. We have an excellent speakers from Italy, from Saudi Arabia, from Canada, from USA, UAE, and China, as well as India. And these are all speakers who knows a lot about obesity, and they are really have experienced the treatment of obesity in their clinics and in their daily practices. Next. Well, this is the certificate which we're gonna get from the American Association of Continuous Medical Education, and we're gonna gain 64 CMEs. That's when you finish the final exam in the CME. Now, each webinar next, like the previous one, where was our speaker, Dr. Khalid and Muna, timing, as I said, from 25th of March 2026. Next. Registration, now it's open, and you can see the QR code. You can just put your camera like that, and let me try with you to see if it's working. Yes, and immediately you can directly take you to the registration, and the registration is open now. Next. This is the fellowship registration link. Again, if you couldn't do it from the QR code, you can just go to this link where the cost is per module 600 USD dollar and 1,000 per whole fellowship. So I advise you to take the full fellowship. It's cheaper for you a little bit rather than by 200 rather than to take each module. But you are free to do whatever you like. This is the landing page for the fellowship where you can have the wiccem.org weight management and obesity medicine fellowship. Next. Now, this is the previous one which we have done. It was 16 December 2025, the first webinar in this fellowship, where we took the people into a nice tour about the new era of obesity care and mindful practice of metabolic precision, where our speakers was Dr. Khalid Suwaifi and my dear friend Muna Jum'a, myself and Dr. Mirey, our guest speaker for today. We were moderating that webinar. Next. And that was the certificate which was signed with your attendance to all our webinars. I can't wait to see you live with us. I hope also you will enjoy today tour, and thank you very much. Now, with no further, I will introduce my second moderation, Dr. Ramadan, and please, can you introduce yourself and take the tour from there?
Thank you, Dr. Wafa. My name is Dr. Muhammad Ramadan, consultant internal medicine and endocrinology. I'm working in obesity management now in Saudi Arabia since about 20 years, and I started my obesity and weight management clinic almost on 2016 when the first medication introduced in Saudi Arabia here in 2016. It's my pleasure to join your team. Thanks, Dr. Khalid, for asking me to join with you this fellowship, because a lot of people is working to progress in their career and to have a work progress, and they don't have many resources, and there is no a lot of fellowship in weight management and obesity. And as Dr. Wafa said, obesity now, like last webinar, is the era of obesity and the era of the medication for obesity and weight management. Obesity is a major disease, and all the health care organization now is focusing about an obesity, out how to manage obesity and to prevent a lot of disease. Thanks again. And now, ladies and gentlemen, it's my pleasure to introduce our next distinguished speaker, Dr. Mireille Karvitian. Dr. Karvitian is a nutritional scientist at the University of Toronto's Faculty of Kinesiology and Physical Education. She holds a PhD in health promotion from Maastricht University and dietetics degree from American University of Beirut. A registered dietitian with over 20 years of experience, she has consulted across the Middle East and now practices in Canada. Her research aims to improve dietary habits for preventing and managing chronic diseases. She developed and clinically validated mobile nutrition and educational app with a related publication available online. Dr. Karvitian had authored more than 40 peer-reviewed papers and is recognized a speaker at the Middle Eastern Nutritional Conferences. So join me for welcoming Dr. Mireille Karvitian, and the thanks for all, and we can start with Dr. Mireille.
Thank you very much for the very generous introduction. Thank you, Dr. Khalid, for having me and your trust in me in this fellowship. And thank you, Wafa, for introducing the fellowship so well. I think obesity is, I don't think we need to discuss it. It is an overwhelming topic in all over the world. It is taking a very big toll on the health burden of many, many people and the healthcare system. And I think every effort that we do in the progress and every education and every fellowship and every CME is just one tiny drop towards the solution. So with no further ado, I would like to start my lecture. These are my socials if you want to follow, and my email. If you want to stay in touch, I like to stay in touch with people that listen to me. And if you have any questions later on, you can also reach out to me. Having said that, I want to dive into the topic directly. So when we're thinking about obesity management, right now I live in Canada, so I would like to share with you the Canadian obesity guidelines. And I think they're all over the world. They're very similar. So first of all, as you, unfortunately, right now, the main indicative is BMI, even though I'm a big advocate for body composition. But right now, BMI is the leading marker. Not that we need to stick by it, but as a starting point, as a screening tool. So when BMI is calculated, if BMI is after 27, then we have to look into, or 30 for non-Asians. For Asians, we need to discuss and look into solutions. And solutions can start with obesity pharmacotherapy, but only if the person has passed through at least 6 months of lifestyle changes. So irrelevant of where they start from, they have to have started from lifestyle change. Now, if lifestyle changes fail, then obesity pharmacotherapy can come and all the others. But, and there's a lot of medications that can come in, like the GLP-1s, bupropion, which decreases the food noise. I don't know how familiar are you with that, but it's, I'm a big advocate of that, naltrexone or bupropion. These days, we keep on hearing about food noise. It's a good food noise calmer. And orlistat, but nowadays nobody likes to use so much orlistat because it has all the side effects of fatty leak and people don't like to use it so much. So having said that, the pharmacotherapies are there, but they do not come without any side effects. So that's why, first of all, 6 months of lifestyle is tried. If that fails, then pharmacotherapy can come, but I want to use this word now to assist or facilitate or accelerate or be a catalyst to the lifestyle change, but it cannot substitute lifestyle change. And I want to a little bit discuss food noise before I go a little bit more. Maybe you're not familiar with the word and how to validate food noise. Food noise is something that every person who has any weight issues, obesity issues, use has it and knows it, and it is basically constant thought of food. Even when you finish eating, you still think about food. And recently somebody asked me, how can you measure food noise and how can you understand if somebody has a food noise? And for example, you can use this tool as pre and post treatment. So this would be a nice validated tool that you can understand what's happening with food noise. And if the treatment you're giving, is it decreasing food noise? Now, there are many ways of decreasing food noise. We'll talk about that. But just introducing everyone what is food noise. Now, the problem with GLP-1s, obviously, you know that GLP-1s is an incretin-based protein, and it is revolutionizing weight loss management. But with this comes that, is it like one solution for all, one solution to all problems or not? Now, GLP-1s are powerful medications and they help you lose weight. But unfortunately, 30%, up to 30% of the weight loss is from lean mass when it is not coupled with exercise and protein intake. But the problem is that very often these days, patients are given these medications that's the growth or the tapering towards the highest dose usually goes very quickly. So people are not given a chance of low dose to actually learn how to build lifestyle changes. Very often they are given very quickly their maximum amount of dose. Once they are given their maximum amount dose, what happens is their appetite is very much suppressed. So they don't feel like they want to eat enough protein, and because of that they feel weak. When they feel weak, what happens is they don't feel like they want to move, so sedentary lifestyle actually increases, and definitely they wouldn't actually go to do lifting weights. And the thing is that if you do not eat protein, then you cannot maintain your muscle, and if you do not exercise, you cannot increase your muscle. So I just want to highlight this, that exercise, the only way to actually increase muscle, and not all exercise, but basically weightlifting with weights that are higher than your comfort zone. Okay, protein maintains your muscle mass, and exercise, weightlifting, resistance exercise increases muscle mass. So here comes the idea that when a patient is being given a very high dose of GLP-1 to achieve a very fast weight loss, they are very often in this cycle that they have very suppressed appetite, very low protein intake, weak enough, not motivated enough to go to exercise. And very often, because they're given this magic drug, what happens is they don't even think that they should actually do other things, like all the lifestyle changes that they have tried before and failed. So here comes the importance of counseling correctly. So muscle loss is not being well monitored when a patient is being given GLP-1, and body composition is not all the time being explained, and the importance of lifestyle change when a patient is being given prescribed GLP-1. So most clinics do not assess muscle mass, strength, function, gait, and protein sufficiency. Yet these are essential predictors of long-term health. Muscle these days is being shown as the anti-inflammatory organ, as the only organ that protects you from all diseases, from all chronic age reversal. Engineering can be actually achieved with muscle. So muscle is not something that we want to achieve. Now I want to, for some reason, I'm not seeing any of you. So I want to see, oh, there it is. I want to see, can we do a quick Q&A? I'm going to unshare my screen and give you two scenarios and see what you're going to be doing. I want to see the Q&As. So just let's imagine two scenarios, person A and person B. Yes, person A is somebody who was, let's say, 120 kgs, and they had all their life been having problems with weight loss. So this is person A. And yes, keep your be ready for typing, attendees, because I want to hear your answers or read your answers. So as I said, person A is somebody who has had always weight issues, obesity, weight gain, the food noise, but this person has been living with a certain ability to exercise and move. Okay. Now, what happens with this person is that they go into a GLP-1 therapy without being counseled well, without being given the right amount of time and effort to make sure that they do follow lifestyle change. And this person A, 120 kilos with a certain percentage of muscle mass, loses weight. After 6 months or 8 months, they have reached to their, let's say they've lost 40 kilos or so forth, but 40% of that usually is from muscle. Now imagine this. They stop the medication, and my slides will come and tell you, but 80% of patients within a year regain the weight. Yes, remember that 80% of patients who stop the medication regain the weight. So when you gain weight and when you're not doing exercise, what do? All of it comes from fat. So now this person A, let's go back to this person, was 120 kilos with a certain muscle mass, reached their ideal body weight or like desirable body weight, and they have much less weight, muscle. 1 year later, they regained it and went back to 120 kilos. So I'm going to call this person B, or let's say scenario B. Scenario B, who is after a weight loss, they've gained back the weight. Is that a healthier person, or the first initial person before treatment is a healthier person? What do you think? So let's call that A and B, even though it's the same person, but they are in two different situations. Let me see what's happening with the chat. What do you think? A or B would be a healthier person? Am I seeing any answers? So somebody's saying B might be a better, so I want to like remind everyone. So A was somebody who started 120 kilos, lost a lot of weight. A lot of it was also 40% of it was muscle. And then they gained back all the weight, but they didn't gain it with weightlifting. They didn't gain it with protein. They just ate regular food, whatever they had, that food noise and their appetite told them to. So this patient B, or version B of the same person, has come back to 120 kilos, but this time they have less muscle. So when they have less muscle, who do you think is healthier, A or B? I would say, very good. I'm seeing the answers A. Yes, exactly. A is the right person because they had, yes, a lot of high BMI, but they had more muscle. They had that protective thing of muscle. So here comes that we should not correct BMI. We should correct body composition. Body composition should be our role. And that's why I started my slide saying, unfortunately, right now, BMI is the screening tool. It can be used screening, but should not be used as an assessment. Muscle mass and body composition should be the ones that we are going for. So here comes, I'm glad that you're engaging with me and you're in with my own mindset that body composition matters. Now, unfortunately, do we have, let me see. Oh, there you go. Sorry, my slides jumped in. Now, I'm happy to say that we are in prime time. In 2025 August, a position paper came out from 4 different societies of obesity in the US, and they called it that it is bad medicine to prescribe GLP-1 without lifestyle change. Now, obviously, lifestyle change is not easy, right? Because if it had worked on its own, GLP-1s wouldn't have come to the market. So the concept was that nutrition has to be prioritized when GLP-1 is prescribed. Now, but what was the recommendation? So one of the recommendations was that structured nutrition advice has to be there, protein optimization has to be there, resistance training, but unfortunately, most GLP-1 users receive little or no guidance on all of these. So here comes the idea that it was a recommendation from these 4 societies in the US in obesity, leaders in obesity management, is that maybe digital tools can be the solution because they are scalable, and they saw that there are not enough digital support for this concept. And digital tools can actually detect early muscle decline, guide patients to protein strength, support day-to-day adherence, but they are not there yet. And millions of users are left unprotected. Now, why this matters now? Because GLP market is increasing. It is the trend now. It is happening. It's the revolution that it's the wave that we are going with. GLP-1 usage is skyrocketing. Adoption is outpacing clinician ability to deliver lifestyle care. New evidence highlights urgent unmet needs. We do not have enough dietitians and nutritionists and physicians for all the patients that are taking GLP-1s to pair them with a constant monitoring and coaching to make sure that they stick by their lifestyle change while they're taking GLP-1s. There are not enough clinicians in the world to actually pair them with this number of growth that is now and projected for GLP-1 users. And I don't know if you know this, but in January this year, I mean, like this year, we can say this year, so it's very new. So very recently, in the past few weeks, the FDA in the USA approved the oral pill of GLP-1s, and it will eventually penetrate into other markets, which means that we will even have more GLP-1 users, because if people were a little bit afraid from injections, then now all those who were not afraid from injections will start taking it. So here comes the 2025 advisory highlights 4 red flags: under-recognized muscle loss, low protein intake across GLP-1 users, poor adherence without structured support, a major need for digital life platforms. So 50 to 60 or 70% discontinue their medication within 1 year. So there is this that also we have to always understand that there is no magic drug. There is lifestyle change, and drugs can accelerate or facilitate, but there is absolutely no magic drug at this point. So here comes that 70% of patients who are on GLP-1 1 year later discontinue the drug. And after stopping, 2/3 of them regain all their weight. 85% regained by year 2. Muscle is not recovered during weight regain. Long-term functional risk. Imagine all the people that right now are on GLP-1s without parallel support from lifestyle change, and keep this in mind, and remember that after age of 40, every decade we start losing more muscle and we become more resistant to muscle regain or muscle maintenance. Yes, so keep these 2 factors and imagine the era that we're going to be going to if we do not attack the problem from all its aspects. Obesity is an issue that needs to be tackled, but what about body composition? Clinics lack the time, training, capacity for weekly nutrition, resistance coaching. They don't have the capacity. Patients need continuous, scalable digital tools. A critical window of opportunity. Science is new, demand is massive, and there are no existing scalable solutions. Without intervention, muscle loss plus weight regain will become the next GLP-1 crisis. So the thing is, if you want, you can take like a screenshot of this. This is kind of like a wrap up of everything I said. 70% discontinue within a year and 85% regain the weight. Muscle is not recovered. Healthcare systems cannot catch up. Clinics do not have the capacity, and science is new. Demand is high, but we do not have enough solutions. So what do you think? Now, this is the guide from the 4 nutrition societies, obesity societies. This was a recommendation that came out. Nutritional priorities to support GLP-1 therapy for obesity. So first of all, we need to manage the GI distress, navigate the dietary preferences, prevention and mitigation of nutritional deficiencies. These are important things that easily can be overlooked. Micronutrient deficiencies, yes, before muscle, even micronutrient. Preserve muscle and bone mass. Bone bone mass. How important is it? We keep on talking about aging and bone mass, and then what if we are stripping people from their ability to have their normal growth of bone mass? Maximization of weight reduction efficacy, promotion of other supportive lifestyle measures. So initiation of GLP-1 therapy with patient-centered approach has to be the key. And this is the most important word, like patient-centered approach, making sure that the GLP-1 therapy, as amazing it is, it actually meets the correct needs of the patient and not overrides or underrides. It comes hand in hand. You know, in medicine, they say first do no harm. So let's make sure that we do not harm our patients while in the hope of protecting them from future problems from obesity. We can't solve one problem and create another. Again, GLP-1s are revolutionizing weight loss, but we need to make sure that we ride this wave safely. Now, digital technologies, characteristics, the advisory board, the one that I mentioned, said that key characteristics have to be that digital therapies have to deliver structured nutrition guidance, support protein intake, resistance training, enable self-monitoring diet symptoms and activity, okay, offer behavioral change, prevent weight regain, and reduce the burden on the overwhelmed clinician. So this is kind of a call to the world to actually respond to this need. Let's create these digital tools that can support our patients. Digital self-monitoring tools can monitor intake, protein quality, physical activity, symptoms, weight, body composition. And the purpose is to compensate for the lack of long-lasting and inconsistent follow-ups within healthcare systems. We cannot see patients on a weekly basis. It's not sustainable. Digital strength and functional tracking. While no specific product names are given, the advisory recommends digital assessment tools that track sit-to-stand stance, function, mobility, and gait, muscle strength trends over time. So these are recommendations that are coming from these 4 societies. And one more thing, they are recommending digital behavior change adherence tools that can be used as goal tracking, habit formation, motivational nudging, feedback loops, long-term behavior support. And finally, the aim is, again, from the advisory board, to make sure that these digital tools support weight loss maintenance after GLP-1 treatments, after the person has reached their desired weight. So to make sure that they do not go into this yo-yo cycle of weight loss and weight gain. Internet-based technologies are booming, and this is not something new. Since 2010, all literature has been saying that they improve compliance and they're low cost to actual visits of dietitians, that they do not replace dietitian, they do not replace the clinician, they complement and assist the clinician. Smartphone technologies, mHealth is an advantageous tool for supporting behavioral health change, and more publications are coming up to say that that is true. And technology interventions curb obesity, and these are all findings from systematic reviews. Now, dietary apps, what are the effective mobile apps or the available ones? They're tools for nutrient calculations, there are self-monitoring, food diaries, and some that are nutrition education, but most apps are mainly tracking. Their reliability and efficacy very often is questionable because not all of them are research-based, not all of them are evidence-based. A lot of them, so I've made like a table on the right side that there are almost no mobile apps for weight loss and GLP-1s that are co-designed with patients. And I believe that the only way to actually be able to create a tool that is effective is make sure that the end user is co-designing it with you, because that way you are not assuming on their behalf what they need. They're actually telling you what they need and you are implementing their needs. And only one app is co-designed, with the clinicians. Tracking muscle and protein, most have just questionable methods that you question the validity of the tool. Sleep tracking, some of them have it. Education, very few have it. Behavioral change, limited the integration of behavioral change. Clinician trained AI chatbots, there are a few. And live dietitian access, there is no app that has a live dietitian access. And the thing is that with one of my colleagues, we've done a systematic review to study the effective or what are the main features for nutritional apps to change chronic disease. And the main features were but before I say that, apps actually showed that they enable daily self-monitoring, increase engagement, provide real-time feedback, apply behavioral change, and address barriers. So these are the impacts of apps. But what were the main features was self-monitoring tools, personalized feedback, evidence-based nutrition education, behavioral change, high usability, simplicity, and cultural alignment. But one of the most important part was that if it was coupled by an access to a live dietitian from time to time, only then this app became a success. And if it was not connected to a live dietitian from time to time, then it was not so effective. Eventually, people started not using it. So that's why I said earlier that apps will not replace clinicians, but they will just assist with the clinicians. This is an evidence-based guideline for prevention of care for type 2 diabetes. I was lucky enough to be involved in this research. I'm showing you the submittal. It is not yet published, and we just submitted recently. And the guideline was why digital interventions matter in diabetes care. Diabetes prevalence is because it's exploding, and part of it was GLP-1s. And digital tools have been seen that they are not just for obesity, but for also diabetes. They are impactful. They can improve glycemic control, health literacy, self-efficacy, empowerment, but they are not evidence-based, the ones that we have in the market. What effective diabetes digital tools must include? Cultural linguistic tailoring. And how do you do linguistic tailoring and cultural, except if you end up co-designing with patients, right? Education, coaching, stronger outcomes. The more education and coaching there is, and as I said earlier, remember, if there is the part where you can connect to a live dietitian, only then these tools become effective. Improve adherence, overcome clinic limitations. The 2025 guidelines, the panel, as I said earlier, says that digital tools, if used correctly, it can improve glycemic control, empower self-management, address inequities in diabetes care among all spectrum of patients. Now, I don't know if you know this about me, but there was a time that I used to work in the UAE as a researcher, and at the time I co-designed with patients a digital app tool for kidney failure patients. It was completely co-designed with stakeholders, with patients, with physicians, and with dietitians, and it was made for Emirati patients, and it was for dialysis. Now, why I say dialysis and why I mentioned that here within this context is, and I would say, why is Mireille talking about the dialysis tool in GLP-1? Well, dialysis patients are categorized as the most incompliant patients across the full spectrum of the chronic disease patients. Now, and why I did this was I wanted to test if an app standalone can actually improve hard clinical outcomes in these patients, then it would fix the story for other things, other problems. So our tool had podcast videos, self-monitoring features, mobile application was not, at the time was not publicly available when we did the randomized control trial. And I'll tell you this, every feature, every picture, every dialect, language, voice, tone was co-designed with patients. We made sure that they told us what they want to improve their compliance. They told us what they want to understand diet better. They told us what they want to see. And when we did that, I am happy to say that we run this app in a randomized controlled trial for 6 months, and it was able to improve serum phosphorus among patients. So what I would like to say is digital apps actually work. And if we invest time and effort to actually ask our patients what they want and how to fix their story, we could actually bring in an era where we can have digital tools and GLP-1s and clinicians work hand in hand to be able to meet this excessive need for patients or the scalable need of patients for support. And maybe we can we can start living in an era where GLP-1s and diet support can fix our epidemic of obesity and reach 10 years later in a place where we have a healthier population and not a sarcopenic population who is thin but sarcopenic, because that would be creating a problem while fixing one. I hope you enjoyed my lecture, and I hope my passion about the topic was clear. Thank you very much for listening. And if you have questions, I can answer also. Thank you.
Thank you, Dr. Merey, for such an inspiring session. It was a very informative and a clear presentation, added great value for me and for all attendees. We truly appreciate the time and effort you dedicated for sharing your knowledge with us, and it was very grateful for your contribution and looking forward to learn from you again. Really, it's a very informative and really we have a lot of challenges as a physician managing patient on GLP-1. One of them is they don't calculate the body composition before starting the treatment. Nobody's doing. All of them are looking for numbers on the weight, for the BMI. Nobody doing the fat composition and the body composition before starting the treatment, just to follow a patient. He's following only weight on numbers and his diet and his appetite and satiety, and that's it. He didn't follow the body composition. At the end, fast weight loss will lead to loss of a lot of muscle mass, which, as you said, it's very important for the muscle mass and anti-inflammatory for our body. Very informative. I like it. And for sure, our attendees will learn from you again how to manage a patient with obesity. Really, I appreciate
We have
your
a couple of
contribution.
questions, though. We have a couple of questions, Dr. Merey. Thank you so much.
Before we take the questions, I would like to share something that is kind of a small secret, but I would like to share with the community, is that
I wanted to say it.
I am in the process of developing an app for GLP-1s with it is partnered with patients from Obesity Canada and the Obesity Society in the US, and soon we will have it. Now it is already ready, but now in a few days I will have patients start giving their input. Within a few months it will be ready, but right now, and we will have it passed by a randomized control trial, and once it is ready it will be available for everyone, and the hope and aim is to protect patients' muscle mass, and with sustainable tools that are scalable. One of the things that I've used in my app is a home kit tool that can be sent to people that they can pee on it and get to know if their muscles are okay. So less hassle on the clinic and more accessible, and people can do it at their home and send their report to their doctors. So I remember when I was in this conference and I heard the story, all I was thinking is we have to find a solution to this problem. And I hope this solution can help people preserve their muscle mass, because muscle is life, and muscle is the only way to make sure that our age becomes irrelevant number that doesn't define us. And muscle is the only way to do that. Let's age with grace, you know. Let's not have aging and GLP-1s strip us from our amazing muscle.
We can't wait to see it. We can't wait. And I know about it. Actually, I wanted to tell you to talk about it, but you always read my mind, Merey.
Thank you.
Dr. Ramadan, will you take the questions for Dr. Merey?
Yes, for sure.
In the chat, I'll take one till you go there, which you start talking about muscle mass and protein. There is from Dr. Abdul Hamid Ramadan as well. Protein intake recommended for those on GLP-1 RA.
I have a suggestion. Shall we, for time purposes, have the other lecture running while I can type some, and then at the end we can take question answer for both lectures?
Thank you so much. Yes,
Yeah,
yes.
maybe
Really.
that, yeah, just for
That
like
would be
not to override the time. Yeah.
Dr. Ramadan, do you agree?
Yeah, for sure, Dr.
Excellent.
Wafa.
I can also type some of the answers while the other lecture is happening.
Excellent. So
Yeah.
let me, till the video is ready, let me introduce our second speaker, Dr. Michelle Cardell. She will talk about the beyond the prescription lifestyle support for GLP success. Dr. Michelle Cardell, she's a registered dietitian, by the way, nutrition scientist, as well as internationally recognized expert in obesity, health equity and behavioral change. She serves as a chief nutrition officer and senior director of the global clinical research and nutrition at Weight Watcher. So from that Weight Watcher, you would know that she have a lot of evidence-based nutrition strategy and clinical research innovation. She's also associate professor in the Department of Health Outcome and Biomedical Informatics at the University of Florida. She's very well known. She has a lot of publication, and her talk today will give us a lead of the GLP-1 and lifestyle. So can we have please, Dr. Michelle talk? Thank you so much.
The newest generation of weight management medications isn't just moving the needle, it's really rewriting what's possible. And in phase 3 clinical trials, once weekly treatments have delivered unprecedented results from pharmacotherapy, with people losing about 15 to 21% of their body weight in approximately a year. Saying, please share your screen. Can you not see my screen?
No.
Oh, I'm sorry about that. I thought that was being shared. Okay, apologies for that.
Yeah, all good now. Thank you.
Okay, perfect. You can see.
Yes.
So people are losing about 15 to 21% of their body weight in approximately a year. And these outcomes were once unimaginable with traditional approaches, and they're redefining how we think about obesity and its treatment. So many of the treatments making headlines like Wegovy and Zepbound do have GLP-1, and they act by mimicking the natural GLP-1 hormone. Others like Zepbound really push the science further, activating both the GLP-1 and GIP receptors to deliver a more powerful combined effect. And what makes these medications so effective is not just the way they curb appetite, it's the way they fundamentally change how the body responds to food. So by dialing down hunger signals, amplifying feelings of fullness, and slowing gastric emptying, they help people naturally reduce calorie intake without that, constant battle. This results in clinically significant sustained weight loss and a dramatically improved relationship with food, outcomes that were nearly unimaginable with older therapies like naltrexone, bupropion, metformin, etc. And as groundbreaking as these medications are, they're not a standalone solution. The FDA in the United States is very clear that every GLP-1 receptor agonist approved for weight management carries the same guidance, and that is that those treatments must be combined with behavior change to optimize health and well-being. So in other words, the medications can reduce appetite and increase satiety, but optimizing that health and well-being still depends on building sustainable habits around nutrition, physical activity, sleep, and other behaviors that support long-term health. I've been in the field for almost 20 years now, and have been fortunate to be part of the development of a variety of standard behavioral programs. And traditionally, what we do in standard behavioral programs is we focus on managing the factors that influence eating behavior in order to, defend that calorie deficit. But the medications actually address those biological drivers that drive that excess calorie consumption and excess adiposity. And so it's a real paradigm shift when we're thinking about developing behavioral weight management programs for GLP-1s, because the switch really goes from thinking about defending that calorie deficit to really focusing on nutritional adequacy, making sure patients are eating enough calories, protein, fiber, that they're getting enough hydration, that they're engaged in physical activity, particularly resistance training, in order to preserve that lean mass. And I know this is a great emphasis of Miri's work. But it's really the powerful combination of this clinical innovation in the medications and behavior modification that's really going to unlock the greatest impact from a weight management perspective, but even more so a health optimization perspective. So, that's why the behavior modifications recommended for people on GLP-1 medications look so different. So we're no longer focusing on that meticulous tracking or anything like that. We really want patients to focus on protein to support maintenance of lean mass, fiber to support gut and heart health, fruits and vegetables to support vitamin and mineral intake, and also thinking about dietary recommendations, where thinking about symptom relief and how are they doing on these. So we want them to have that broader set of diet and lifestyle recommendations. So like I said, protein really remains at the top of the list, particularly animal proteins, which are going to deliver more protein per serving than plant sources. But we can also, reach our goals with plant sources. Fiber is going to be critical for that gut and heart health. Fruits and vegetables are going to help ensure adequate intake of vitamins and minerals that might otherwise be missed when total food intake drops. Symptom management, is key. Constipation is a common side effect of GLP-1 medications, and proper hydration can make a meaningful difference in easing discomfort and keeping digestion on track. Additionally, we want patients to avoid, where possible, fatty, greasy, fried foods, because we do see an uptick in the nausea, vomiting, and diarrhea when people eat that. Similarly with foods that are higher in added sugar. And then, of course, the lifestyle behaviors are going to play that pivotal role. We want the strength training to preserve the muscle mass, while the aerobic activity is going to support cardiovascular health and overall well-being. And together, these strategies are going to give patients a strong foundation to not only lose weight, but again, maintain their health and process. So with this, our team developed a tailored behavioral program for those on GLP-1s, which we coined the GLP-1 Companion Program. This program helps focus on nutrition and activity while the medications support their weight loss. So within the GLP-1 Companion platform, we provide daily nutritional targets. And I want to be clear that these are minimum targets that we're recommending, which patients love, because most of our patients, have been tracking protein or macros or points or calories or whatever, often for decades at a time. And it always has a ceiling. You have to eat under whatever it is, 1,200 calories. You have to eat under a certain amount of points, and for the first time, we're telling them, okay, we want you to get minimum. We want you to get a minimum of 1 gram per kilogram body weight of protein. We want you to get a minimum of 4 servings of fruits and vegetables every day. And this is just a starting point, when they're on the medications and they're titrating up, when they have significantly reduced appetites and food aversions arise. We want them to build over time to get, significantly above that. Similarly, we want them to get at least 8 cups of water a day. We also provide the daily targets of at least 30 minutes of daily activity and strength training 2 times per week. And then in addition to daily targets, we heard from patients that, they experience extensive weight-based stigma, bias, discrimination. And so, they tell us, I was stigmatized for living in a larger body, and now I'm being stigmatized for being on a medication to address, the chronic disease of obesity. So people are like, well, you need to lose weight. And it's like, but no, not like that. And so they're feeling that double stigma. And so we hear from them that they're looking for non-judgmental community that can support them throughout the whole process, that understand that shared journey. So in our program, we also created the community component. So members have access to what is called Connect, which is a members-only social community, which has special groups for, people on these medications. The members also have access to 24/7 live coaching, and they also can participate in virtual workshops that are tailored to GLP-1 program members and gives them that opportunity to talk with other individuals who are on medications and, experiencing the same journey. So to evaluate this program, we conducted a clinical trial in partnership with Dr. Leslie Heimberg at Cleveland Clinic to assess its efficacy. And this was a 6-month single-arm clinical trial. 180 participants were prescribed a long-acting GLP-1 medication, either semaglutide or tirzepatide, with access to our GLP-1 companion program, the workshops, as well as registered dietitians and fitness coaches. So going over the clinical outcomes first, over the 6-month study, participants lost on average about 12.3% of their body weight. This equated to an average of about 27.4 pounds lost over 6 months. Of note, 67% of participants lost more than 10% of their body weight at the 6-month mark. With regards to blood pressure, participants experienced a 7.8% reduction in systolic blood pressure, dropping it by 11 units, and a 5.8% reduction in diastolic blood pressure, reducing by almost 6 units. Moving on to behavioral outcomes, participants using the GLP-1 companion program significantly improved their diet quality. So this is very different than what we see, for example, with bariatric surgery, where with bariatric surgery, often people are consuming less calories, but their diet quality doesn't change. We consider it to be clinically significant if somebody's healthy eating index score improves by 3. So healthy eating index score is a measure of total diet quality that's scored from 0 to 100, with higher numbers meaning that greater diet quality. So, here we're seeing about a 10-point improvement, or, almost a 35% improvement, increasing it significantly, both from a statistical perspective, but also from a clinically significant perspective. After using GLP-1 medications and the GLP-1 companion program for 6 months, participants also significantly increased a number of healthy habits, including considering portion sizes, self-weighing, considering the protein content of foods, and other things like being physically active, talking kindly to oneself after a setback, and planning meals for the day. The 66.2% increase in considering the protein content of foods was huge, considering protein intake is one of the primary behaviors we drive with the program. And this really demonstrates that with structured education and support, patients on GLP-1s do start to think more about protein sources, which we know when combined with resistance training is extremely important for lean mass maintenance on these medications. Additionally, participants reduced their less healthy habits, including decreasing their consumption of fried foods, consuming less cookies, candies, pastries, and sweets, and drinking less sugar-sweetened beverages. With regards to activity, participants increased the number of days per week they do strength training by 53.2%. That sounds really big, but I do want to make note that this was, an increase from 2 days a week on average at baseline to 2.5 days per week. They're also increasing the amount of time they spend in physical activity and decrease their sedentary time by over an hour per week. We also measured a series of psychosocial outcomes in the study. Participants significantly increased their overall quality of life by 53%. And of note, when looking at the subdomains of quality of life, participants improve their physical functioning, their self-esteem, their sex life, their public distress, as well as improvements at work. Similarly, participants significantly improved their body appreciation by 17% and reduced their weight bias internalization by 10.8%. And that piece I think is really important because, again, experiencing the stigma that patients often tell us that they've had throughout their life, a lot of times patients have internalized that weight bias and stigma. And what we see is often when they get on these medications, it's almost like a light goes off and they're like, oh, it really was my biology that was driving this. This wasn't a reflection of me or my character or my willpower. It really was a reflection of, my body and my biology fighting me at every turn. We also measured hunger and food cravings. Participants experienced an almost 33% reduction in hunger, which is, expected on these medications, and an 18% reduction in food cravings while using GLP-1s alongside the GLP-1 companion program. When looking at eating behavior, participants reduced their emotional eating by nearly 27%. They also increased their restraint or intention to moderate their food intake by about 35% and decreased their disinhibition or overeating by 35%. One of the big questions that comes up with these medications is, are these medications going to contribute to disordered eating pathology? Are we going to cause more eating disorders with these medications? And we're actually seeing the opposite in our studies. Participants actually reduced their disordered eating pathology by about 27%. This is significant. We're seeing improvements in their focus on eating concern, on shape concern, weight concern. There was a patient that I was talking to, on average, before getting on a medication, she was experiencing about 2 to 3 binge eating episodes per week. She did have binge eating disorder. And after 2 years on the medication, she had not had a single binge eating episode since she had gotten on the medication. So I think we're going to see a lot of evolving research in that area. Participants also significantly reduced their perceived stress by 3.7% and their perceived depression symptoms by 33.8% following the 6-month intervention. Not only has this been proven effective in clinical trials, but we're also seeing similar outcomes in the real-world evidence as well. So we retroactively examined data from over 53,000 patients who were taking GLP-1s or another weight loss medication. And this includes GLP-1s, but also things like naltrexone, bupropion, metformin, et cetera. So in the span of 12 months, we saw that patients lost on average about 21% of their body weight when taking GLP-1s and 19.4% of their body weight when we looked across a variety of anti-obesity medications. And this is very similar to what is observed in pharmaceutical trials. When looking at longer-term outcomes, after 18 months, members lost an average of nearly 19% of their body weight. Again, this is just for GLP-1 medications. And after 24 months, members lost an average of about 20.5% of their body weight. So you see they're kind of, hitting this nadir around 12 months or so and kind of staying, within 1 or 2% of their body weight loss when they stay on the medications continuously. So overall, today's findings really highlight just how transformative, GLP-1 medications can be. They don't just drive clinically meaningful weight loss. They also improve blood pressure, diet quality, and can help drive healthy habits. But the real power comes when medication is paired with behavior change. Programs that emphasize protein and fiber intake and hydration, along with strength training, can amplify these effects, supporting not only greater physical health, but also stronger behavioral and psychosocial outcomes. So I want to take a moment to thank all of my many wonderful collaborators and everybody who was able to make this work happen. And of course, thank you to our clinical trial participants and the millions of members we really have the honor to support on their health journey. The newest generation of weight management medications isn't just moving the
Unfortunately, Michelle couldn't attend this live, or else I think she would have been a great addition because of time differences and previous commitments. That's why she was able to send her recording.
Were you able to see the questions, Dr. Mireille?
I've been answering most of them.
You have been answering. Yes, I can see that. I can see that. There was a question from Bilal. Did you answer that? Dr. Ramadan is with us, I believe. You can take one question from my side, one question from your side, Dr. Ramadan.
I see the question of Mr. Bilal. He's asking about the dose of the semaglutide, dose was 0.25 units per week for 4 weeks, then increased to 0.5 for the next month, then started the patient to suffer from severe GI issues, vomiting, diarrhea. Then he's asking whether to keep the patient at 0.5 or to increase to the higher doses. The doses for the GLP-1 is designed for the side effect and the patient to tolerate the medication, not for the weight loss. Some people lose weight on the first dose and second dose more than the higher dose. So if the patient suffered from vomiting and diarrhea, you have severe GI issue, he have to follow with his doctor first, and then he have to keep on the same dose or to lower the dose if the side effects is very severe. So I recommend for this patient whether to lower the dose for 0.25 for more than 1 month, then increase to 0.5 the next month, and keep on 0.5 until the patient will be safe and tolerate the medication. So we can go for higher doses like 1 and 1.7 and 2.4 and etc. And every month the patient have to follow. And as she said, Dr. Mireille, we need to follow the patient at homes. And it's very difficult to come to the clinic. So online consultations and the using of app will facilitate to follow the patient from diet, muscle, and also the doses for the medicine.
Oh, thank you, Dr. Ramadan. There's an addition from your side, Mireille, before I go for the question. This question.
No, because that was very medical, and I'm glad that Dr. Ramadan was here. It was outside of the scope of a dietitian.
Yeah, exactly.
Yeah,
Mr. Saeed Ahmed also, you might answer this as well, Dr. Ramadan. Saeed Ahmed, is there any patient post-renal transplant on GLP-1? For your knowledge?
Yes, for sure. There is a lot of patients started post-transplant to gain weight from medication and from the activity, decrease in physical activity. The GLP-1 can be for patient with renal impairment, but you have to ensure, first of all, good hydration. Good hydration is very important with the GLP-1 and can be used for patient of post-transplant.
What about how much is to control the HbA1c level after 6 months of treatment in GLP-1?
Again, sorry, I didn't catch
Bilal,
your
the
question.
same Bilal, he asks about how much it control HbA1ca after 6 months of GLP treatment. How much it decreases the HbA1ca for your with your experience.
According to the medication, I have a different patient, but it reached from 1.6 to 2.2 decrease in HbA1c within 6 months, and some patients get more according to their weight loss. But 1.6 and 2.2, and according also medication, which medication are you using for GLP-1, the daily medications, the semaglutide, the tirzepatide, but it reached to from 1.6 to 2.2 for HbA1c reduction.
Very good. The rest of the answer is about the rest of questions is about the certification and the attendees certificate for this today. Other than that, Mireille, I saw that you have answered the questions. Thankfully, in the while we are having Dr. Michelle talk. Okay, can you mention the best GLP medicine for the client to give?
But
I can answer this, but
really,
again,
this is a very challenging question.
yes,
For me and my patients, all GLP-1 are very powerful, but you have to select the right patient and the right way to treat the patient. All of
true.
them I can use because there is a lot of factors, the socioeconomic factor for the patient, also the cost. Is it a cost effective for the patient and he can cover for this? Because in our country here, the insurance is not covering the medication for obesity. So the cost is very important also. It's not about to choose a medication and the patient cannot afford it for 12 months or 6 months. So it differs from one patient to another, according to the cost, according to the patient, BMI also. Why to give a patient, he want to lose 10% of his weight, a medication that can lose 22% and he have to pay more. The cost is very important.
We have here in UAE the insurance they cover, but under a criteria. GLP, the HbA1c.
I know.
Comorbidities, they have criteria. Other than that, it's not covered. They thank Dr. Mireille for insightful talk. They want the link and the certificate, the link for the certificate, and that's most of the questions. They thank you, Mireille and Dr.
I would like to comment on Michelle's talk, and
Michelle.
why I wanted to make sure that she's here with us is that with Weight Watchers, their success was that they actually prescribed, they had a multidisciplinary team that every time a patient was prescribed the GLP-1, they were not allowed to start the GLP-1 with Weight Watchers unless it was parallel to a lifestyle change. And so they called it GLP-1 companion, and that GLP-1 companion had many features, kind of all the features that I expressed, but it was continuous mentoring and monitoring and coaching and even peer group meetings. And eventually it reached to a success story. They were able to reach to a point that they reached their desired goal. They stopped the medication. They continued losing weight after stopping the medication, not just maintaining, but continued losing weight. So this is like a evidence, proof, like GLP-1s are really amazing tools, but whether they are like thyroid medication that should be taken for life, or they should be taken to accelerate and facilitate and improve abilities of self-efficacy of people to apply diet and lifestyle, here is the question, right? And maybe we should more think about, as I think Razan also mentioned, that every time a patient is prescribed a GLP-1, maybe they have to refer to a dietitian also.
Actually, I
And
want to
explained how important it is. Sorry, Wafa, please go ahead.
No. I just want to agree with you exactly what you said. I have it in my clinic as well. And the patient who have followed the lifestyle with proper medication, they lost weight and the muscles. That's why I thought you're talking about B, that it is the one which lose muscles. It's actually the one who did not follow a diet and lifestyle with exercise. They reduced muscles and increased fat. By the way, I have even a study on that. I did it and the one who continue with a lifestyle, continue exercise steps, imagine with just 3 days a week, doing cardio with a little bit of lifting, they did really conserve their the muscles, and yes, the muscle mass, and reduce their fat. And even when they stopped because they want to get pregnant, I have 2 cases, they got pregnant. And that was a success story. They didn't regain the weight, only the baby's weight. And that tells you that lifestyle is very important. So I do agree with you, because you see it, I see it in our practice. They have to come to us, Dr. Ramadan, with your support as a physician.
Together, hand in hand.
Yes. It's a multidisciplinary team for sure. Now, no more.
Dr. Murray said something which is very important. Lifestyle modification, it's not so easy. It's not so easy as people imagine that to do lifestyle medication. It's not so easy, Dr. Wafa. It's more difficult than prescribing GLP-1 medication.
It's not easy, but you have to be convinced, Dr. Ramadan. See, she had an aim. She want to get pregnant. She followed. She had an aim. So motivation and making sure that this is not a diet. It's a changing one at a time, one of my habits. It doesn't come all together, by the way, which I'm going to talk about it in the next webinar, strategies and consensus, because you have to do one at a time. You have to take one habit at a time to change in order to have the lifestyle, because it is difficult, like you say. Exactly. Both Mireille and you are absolutely right.
Dr. Wafa, I will tell you from my experience, the 3 most common motivation for lifestyle modification. The first thing you said, the patient, she want to get pregnant. Maybe she's complaining from PCOS or have some hormonal imbalance. She want to get pregnant. The second one, she's afraid to go to bariatric surgery. She's afraid to go to the bariatric. The third one, she have a party and she want to look good in the wedding party. This is the most common. This is the most common I'm seeing in my
Good
clinic.
Motivators.
You will not.
I agree, 100%.
But we are
100%.
overlooking, but I think we are overlooking the importance of the medical doctor's advice. So I'll tell you an example. A friend of mine decided before he knew that I'm into this GLP space, he decided to ask his doctor for GLP-1 medications. But that doctor is knowledgeable enough to understand that GLP-1 can be harmful if not paired with lifestyle change. So she actually advised him, said, are you ready to do lifestyle change? Because I will not prescribe you this if you don't do lifestyle change. And he said, no, I don't want to do lifestyle change. She said, I will not give you the drug. So doctors are the actual gatekeepers to a better practice. And integrating these two together, the dietitian and the doctor, I think, would be the best way to allow this revolutionizing medicine to actually help these patients. And then patients can, we all came to this practice to help patients' healthcare. So maybe we can all work together on that. And this friend decided, actually, said, oh, wait, I remember Mireille, my friend, the dietitian, so let's go ask her what we do. But that was the reason, you know?
Let me tell you a funny story.
Before the dress, before the wedding, we didn't have any of those. One word from the doctor.
Wallah, I'll tell you one thing which is very funny. I had a patient came from our bariatric surgeons who love, bariatricians. They don't like to go for a lifestyle. They want to cut and do their job, And the insurance to approve that, they have to have 6 visits with me. So every time the patients come, hi, Dr. Wafa, please write for me that I came to you. I said, but you didn't follow the diet. I don't want to follow. I want to go for cutting. And but I said, the bariatric surgery, after you do it, you will have lifestyle different. You will eat little. You will have all your life have supplementation and all of that. She said, I don't mind not to eat. I want to go back to that wedding dress. So imagine she comes to me blocked. Khalas, she wants to do the bariatric surgery. No GLPs, no diet, no lifestyle. She wants to go back to the size 6 before she got pregnant and married. So some people, the mindset doesn't change, but some people, they really obey because they are convinced from the doctor. And I thank them because they tell them to go to the dietitian because she is the key for them in order to give the good medication. And the doctors are really the first key, as Mireille said. You are the one key to make our life easy with those patients because they have to, at the end, mahkina, lifestyle is difficult. So to comply, we need help from you guys. Right, Mireille?
Yeah, thank you.
Hand in hand. Hand in hand.
I totally agree with Dr. Wafa and Dr. Murray. It's a very nice conversation. I like what you're saying, both of you, by the way. It's a real life treatment. It's not like a conference and saying medical terms and medical knowledge. No, it's a
We
real
are
life.
realistic, yeah, doctor. We are realistic, both of them.
It's really very real. You are both are very realistic. And thank you for joining us today.
Mireille, thank you so much.
Thank you. Thank you.
Again, Michelle, Dr. Ramadan, Khalid, and all our audience. Also the organizers for making this webinar as, let's say, live as possible. So thank you so much. Honestly, I enjoy it very much, Saraha. Mireille, thank you so much for your time. As always, a star.
Thank you for having me.
Together. We are lucky.
Together.
We are lucky. And Dr. Ramadan, we are honored to meet you. We thank Dr. Khalid for this opportunity and hopefully to meet very soon in the second webinar where I will talk about the changes and the strategies. So wait for me with Mireille as well and hopefully to see you next time. Thank you so much and have a nice.
Thank you for the attendees. Don't forget, you can learn more about this in the fellowship.
Yes, don't miss the fellowship. The link is there. Don't forget to take it. Thank you. Bye-bye.
Thank you. Bye.
Bye.